Uh, and good morning if you're in America or in Australia. My name is Edwin Ruhinda, and I'll be doing your presentation today. I'll be taking you through fetal cardiac ultrasound. I do have a passion in fetal medicine, and that has seen me do intensive training at King's College with one of the world-renowned professors of fetal medicine, that is Kypros Nicolaides. And I'll share a bit of what I learned through my journey with you today. Benjamin, if you'll allow me to share.
Yes, go on, Edwin.
Thank you. So as the presentation loads, I wanted to tell you the scope of the presentation today. I tried to put as much as possible into today's webinar, but towards the end, it dawned on me that it's a vast topic. I cannot just simply cram it into a single webinar. So what I managed to do is I completed the section on screening, and I pulled out the part that talks about fetal cardiac abnormalities and their diagnosis, and I want to present that as a part 2 in the days to come. So I'll be letting you know. So today I'll strictly concentrate on the screening bit of it, and I'll go into the details of the different views and the different measurements that one can do within the screening views. And I'll show you some of the biometries that you can take within the screening views. I'm quite optimistic that at the end of today's webinar, whoever has attended should be able to confidently perform a fetal cardiac scan and diagnose some of the major abnormalities. So I don't know if my screen is showing.
Yeah.
Perfect. So my name is Edwin Ruhinda, like I told you, and I'm a fetal medicine specialist sonographer here in London. And without wasting any time, this is what I'll be covering today. And I'll turn this off so that we don't lose focus. So we'll be looking at cardiac screening versus echocardiography. I'll try to define for us what this means, because not in many cases you hear people say I'm doing fetal echocardiography when actually they're doing cardiac screening, and the two are somehow separate and different. Then we'll try to see the justification of cardiac screening. Is it really necessary? And we'll look at the indications for echocardiography. We'll look at a brief embryology. We'll look at the technical aspects of cardiac screening. Then we'll look at the main views of screening. So we'll look at the situs view, we'll look at the 4-chamber view, we'll look at the LVOT, the 3-vessel view, and the 3-vessel trachea view. So much of my talk is modeled on guidelines by ISWOG, Fetal Medicine, and the UK's Fetal Anomaly Screening Program. These are where I get the literature I'm going to present today. So before we go any further, what is it? What is fetal echocardiography and what is fetal cardiac screening? So cardiac screening is just part of the routine scans that we do at 20 weeks. And now there's a move to even bring this screening as early as first trimester. But it's just that screening that every woman gets. So every pregnant woman gets fetal cardiac screening. They are simple programmed views of the heart that everyone should have a look at to be able to say this looks like a good heart and this looks like a problematic heart. And then with a suspicion of cardiac abnormality, you get to send or you get to refer this pregnant woman for fetal echocardiography. Fetal echocardiography is that detailed and specialized examination, and it is carried out by people who are specialized in fetal echocardiography. Usually, the hierarchy of these specialists is will you have sonographers doing screening, and then you have specialist sonographers doing the next level of echocardiography. You have these being overseen by consultant fetal cardiologists. These consultant fetal cardiologists morph from pediatric cardiology. So these are people who have studied cardiology and then gone to master into or go into specialized into pediatric cardiology and then go on to do fetal cardiology. And so I'm sorry, I have to break your neck, but this flowchart describes the fetal anomaly screening program pathway. This is what we use in the UK. So if you look right at the top, let me see if I'm able to, right at the top here is where you ask the woman if they want to do any screening. And this screening is just not for the heart, it's screening for everything. So it's a screening for fetal abnormalities. Every woman is offered that choice to say yes or to say no. If if a woman says yes, they would like to have the scan, which most women do, then you go on to do the fetal anomaly screening. And within that is where we have the cardiac screening as well. Now down here, if everything is normal, then the lady goes on to until delivery, basically. But if there's a suspicion of abnormality, then the woman is offered specialized examinations, which some of these might be different from ultrasound. It might be an MRI, it might be blood tests, it might be invasive tests. And at this level is where we have echocardiography. So the beginning there is where we do the cardiac screening, and right there is where fetal echocardiography falls. And then depending on the findings of fetal echocardiography, a management plan is made for the patient, or they're given a choice on whether to proceed with the pregnancy or whether they want to terminate the pregnancy. That is if in the country where they are, that is acceptable. So the question to ask is cardiac screening necessary? And to answer the question, I would say that the short answer is yes, it's necessary, because congenital heart disease is the commonest of all congenital abnormalities, happening in about 8 in 1,000 births. And half of these will go on to require surgery. I tried to put it in context and looked at some of the busy hospitals like in Africa. Say, for example, Mulago Hospital, which delivered about 33,000 babies in just 1 year, that is 2019. Using these statistics, it means roughly there would have been about 264 heart abnormalities within that year alone. And then half of these, that is 100 and something, would need either surgical intervention or catheterization or something like that. So same thing with Kolebu Hospital in Ghana, with around 11,000 births per year. That gives you a good 88 cardiac abnormalities every year, and that is a huge number. So screening is definitely important, and it is vital. If you look at this slide here, it talks about the global burden. So in 2019, about 18 million people died of cardiovascular disease, and a quarter of these, 3/4 of these were in low and middle income countries, where Africa and most of Asia and the Southern Southern America belong. 3 to 18% of these diseases are congenital, and this is about 14 million. So it's a huge number. So I'm talking about 18% of 18 million. It's a huge number to just think it will slip through the system or let go like that. So screening is definitely vital, and everyone should be involved in the cardiac screening of pregnancy. And this is something we should preach to our pregnant women and our sisters and our mothers, so that everyone at least gets a chance to have an ultrasound scan to look at the baby's heart. This global map, the bluer the color, the better for you. The lighter it is, then the higher the burden for you. And as you see, most of sub-Saharan Africa is quite light, and that shows you the disease burden. So before I talk about the indications for echocardiography, what are the indications for screening? So indications for screening, everyone gets screening. So there's no single indication for screening. If you're pregnant, you're eligible for screening. You're a candidate for screening. And who gets echocardiography? So these are the special type of people who get specialized cardiac scans. The reason every pregnant woman cannot get echocardiography is because it is resource intense. It requires specialized people who are trained in echocardiography. It requires time. It requires a lot of resources. So not everyone can undergo echocardiography. So I listed some of the indications and I clustered them depending on their pathway. So for example, some of them are due to fetal reasons. For example, if a lady went through screening and there was a suspicion for heart abnormality, then that is a cause, that is a reason for echocardiography. And this happens in about, abnormality will be picked up in about 50% of all these women who are sent for echocardiography on suspicion of abnormality at screening. Then other reasons like arrhythmia, where we have tachy or bradycardia, increased nucleotranslucency as well is a good reason for a baby to have echocardiography. And the reason for this is because a nucleotranslucency above the 95th centile, nearly half of those babies will have heart defects. 44% to be specific will have heart defects. So definitely increased NT is a reason for that. Babies with extracardiac abnormalities, such as diaphragmatic hernia, exomphalos, duodenatresia, cystic fibrosis, cystic hygroma, all these tend to have heart abnormalities. So whenever you're doing an anomaly scan and you see these abnormalities, then it is imperative that you have a critical look at the baby's heart. And if you have a referral system that permits you, please send this lady or this pregnant woman for echocardiography. We also have things like abnormal loading conditions. And by this, I mean anything that puts an abnormal amount of pressure on the heart. Things like agenesis of ductus venosus. So if it is missing, it means blood flow will just shunt directly to the heart and through the liver to the heart, and that will cause a lot of flow to the heart. This, in the long run, causes it tires the heart. Things like arteriovenous malformations, things like teratomas. If they are huge teratomas, they might drain all the blood towards themselves, causing anemia, and in turn, this anemia will cause a lot of workload for the heart. So some of these are sort of like indirect indications for one to have echocardiography. Then in twins, like TTTS, when you have twin transfusion syndrome, babies with TTTS will tend to have cardiac abnormalities as well. Okay, so let's see. Some indications are historic. For example, if a mother has a history of congenital heart disease, there's an 8% increase risk in having a baby with a cardiac abnormality. So usually, depending on the abnormality as well. So usually, whenever a mother has reports a history of congenital heart disease, then we usually refer the woman for fetal echocardiography. The father is a slightly reduced chance. So if the father of the baby has a history of heart disease, there's a 2 to 3% increased risk in having the baby with a cardiac abnormality. That's almost the same percentage as if that same baby has a sibling who has cardiac abnormality. Uh, some some indications are maternal. So, for example, drugs. If the pregnant woman is using drugs, for example, ibuprofen. Ibuprofen leads to premature closure of the ductus arteriosus, especially if used in the third trimester. So women who have unknowingly used ibuprofen will be sent for echocardiography just to have a look at the ductus arch to make sure that there's no obvious narrowing on there. Some exposures to drugs like lithium. Lithium is used in psychological conditions like bipolar syndrome or psychotic disease. And women who usually take this will tend to have cardiac abnormalities. The commonest example for that is Epstein disease. Women with diabetes or other metabolic diseases are at increased risk of having a baby with cardiac abnormality. There's a 3% increased chance in women with diabetes. And usually, if a woman has pre-existing gestational diabetes before the pregnancy, they are sent directly for fetal echocardiography as part of precaution. Then we have infections like parvovirus. Parvovirus leads to anemia. It attacks the bone marrow centers that produce red blood cells and causes anemia. And this will put a lot of load on the heart. So usually patients who are confirmed infection of parvovirus or some other like Coxsackie virus will usually have fetal echocardiography. And then there's been an association between IVF or assisted fertilization with heart disease. So as a precaution, women who have IVF will also get fetal echocardiography. And then obviously we have the maternal antibodies like the anti-Ro and anti-La, which will cause fetal arrhythmia. And these and so many other antibody conditions which might cause anemia will be a reason for you for the baby to be looked at critically by the fetal cardiologist. So is echocardiography necessary? Of course it is. I know some people will ask, what is the use of finding out if the baby has a defect? But remember, this helps to one, it helps the parents to make informed decisions. It also helps them to mentally prepare. You know, if they are prepared and know that this is what they have, maybe they can learn to live with it and try to uh, enjoy their pregnancy as much as they can before disaster strikes. But also in areas where services do permit, some of these conditions are corrected either by surgery in utero or surgery after delivery. And this helps, fetal echocardiography helps to make that decision. It helps to make that plan of how and when this intervention happens. And remember, it also informs on where these ladies deliver. So if a diagnosis is made, decisions on how the lady delivers, whether it's a C-section induced or a natural delivery, and where, because some of these patients need to deliver in hospitals where there is a neonatal intensive care unit, a NICU. And these are all decisions that are made after fetal echocardiography. So let's have a brief look at embryology. I'll not bore you with too much talk. I just want to briefly go through it because at least it will help us to understand how early this heart forms. So the heart starts to form at about 20 days from fertilization. So 20 days is about 3 weeks. But this is 3 weeks from fertilization, not gestational age. Gestational age counts from last period. So in actual sense, this is 5 weeks gestational age is when the heart starts to form. And it starts as um, as these two cardiac tubes. And then they'll go through a process of fusing and then looping and then rotating and finally um, by about 35 days, you'll have a somewhat formed heart. And between when this starts and when this happens, it's just 2 weeks. So in about 2 weeks, the heart will have gone through all this complex embryological process to form a, a rough figure of a heart with all the chambers in there. And by 8 weeks after fertilization, that is 10 weeks gestational age, the heart as we know it will be fully formed with all its chambers, the 4 chambers and the valves, it will be formed. But of course, at this stage, it is quite small. It is the size of a grain of rice, you can imagine. And it's still functional. It beats as fast as 160 beats per minute, but it's in there. So by 10 weeks, your heart is already formed and it is there working, busy. That said, what do we need in terms of technical, whether it's equipment, what do we need to look at the heart? And allow me to use this example of a Formula One car to explain to you some of the technicalities and the technical challenges that are involved in looking at the baby's heart. So if you look at the car on top and the car on the bottom, if I sent you to a Formula One racetrack and I told you, please take for me a photograph of a car, most likely you'll come up with a picture like this. And the reason for this is because these cars are super fast. They are faster than the rate at which your camera can take a picture. So for you to compensate for that, you have to have a camera with a high shutter speed. So shutter speed is the equivalent of frame rate in ultrasound. With a high frame rate, you're able to capture images of even those organs that are moving pretty fast, like the heart, like the fetal heart. Remember, the heart is beating at 160 beats per minute. That's a lot of times per minute. And for you to be able to get a decent picture, you need to have an equipment that has a high frame rate so that you're able to capture a good image. And this frame rate helps you to, a high frame rate gives you a um, high resolution as well. So, and by frame rate, I mean, if you look at this image right there, what I circled in red, that's frame rate. So my machine will show you frame rate up there. It's a number with has. So that's 37 frames per second. Different machines will show it differently, but you should learn to look at these numbers and try to see how to improve these numbers. So for example, if you're doing a cardiac scan, you want to make sure that your frame rate is somewhere above 30 and 40. So if it's above 40, that's good. Anything above that, that is acceptable for cardiac scanning. Anything below that, you most likely will not see the valves because they are beating faster than your machine can see them. And remember, even high frame rates of about 100 that's 100 frames per second, might be needed if you're going to do things like speckle tracking, which is like functional imaging of the heart. So look at what happens to my frame rate when I narrow the sector width. Sector width is how wide or how fanned out the ultrasound beam is. So the wider the ultrasound beam, the slower it is at taking pictures. Because it has a wider area, it means it has a lot of information to take in, process, and output as an image. So if your machine has a capability of narrowing the sector width, it would improve your frame rate quite significantly. And I've shown you that right here. So that was a wide frame rate. This is a narrow frame rate and a wide sector width and a narrow sector width, and that improved almost double to 73 frames per second. And you also have to learn that there are some things that do affect your frame rate. So there are some things that bring it down. For example, if you're doing Doppler and you're putting Doppler spectral color, this bogs down your frame rate to something like 4 hours. That's quite slow. So you have to learn some of these technical bits of the scan and learn how to troubleshoot and improve them. Reducing the sector width will improve. Uh, Reducing the depth will improve your frame rate, and taking out unnecessary functions like power Doppler and what have you, if you don't need them, will actually improve your frame rate. I have summarized this in this table here for you to see. So the higher the frequency you have, the better for you to do cardiac scanning. That is very obvious because high frequency improves resolution. Frame rate, as I've talked about, improves resolution because you get to see the structures much better. And dynamic range. So dynamic range is the contrast of the machine. Usually with cardiac scanning, you want to have a smaller dynamic range so that the images are quite bright. Doppler capability, if you have that, it is a plus for you. Is Cine loop. This is a very vital part for cardiac scanning, and I'll get to show you how important it is. I'll just give you a small view of what it does. Focal zones, so reducing the focal zones to only one does have a great impact on improving frame rate. Tissue harmonics is also good, and magnification, remember the heart should fill about 30 to 50% of the image. Okay. So let's look at the situs. And to determine the situs, or basically laterality of the baby, you just have to imagine yourself as the fetus. Try to position yourself in the same way as the fetus is and see which side is your left side and which side is your right side. To me, that is the easiest way. I know there are different ways. There are people who will tell you use the rule of the thumb, use the spine, but I find this quite simple to use. Imagine yourself as the fetus. If the fetus is facing you, then most likely this will be the left side and that will be the right side, unless they are in breech, unless they are encephalic, and then you have to orient yourself the same way to figure out. This I find very practical because it is easy to imagine yourself as a baby and try to work yourself out and see which side is left and which side is right. Once you've determined which side is left and which one is right, then the next part is simple. So um, to do a scan of the heart, you start with the situs, because you want to know which side is left before you can actually start going straight for the heart. I've seen people go straight to the heart and say, oh, LVOT, but how do you know it is LVOT if you have not known where the baby's left side and the right side are? So first, you start with situs. Ascertain which side is left, ascertain which side is right. Once you've determined which one is right and which one is left, then you can start cardiac screening. And you start this as a transverse sweep from the abdomen to the inlet. And have I managed to make this small video for you to appreciate? And as you go along, you start from the abdomen, look at the stomach, look at the abdominal vessels, sweep further up, get to the chest. You get to see the four-chamber view. You have to make sure you have one rib on each side of the four-chamber view. Go on, angle slightly cephalad, and you have the left outflow tract. And then further up, you have the three-vessel trachea view. And a bit further up, a bit angled to more cephalad, you'll have the three vessel trachea view. I'll get into the details of these in a second. But I wanted to show you that in a single sweep, you can actually do an entire cardiac scan right from situs all the way to three vessel trachea view in just one sweep. Let's go into the details of situs. So in a normal baby, you should see the stomach on the left side of the baby. So you look at the baby, ascertain which one is left, ascertain which one is right. Look for the stomach and make sure the stomach is on the left of the baby. The descending aorta, which is this, should be slightly on the left of the spine. So that's the spine. And the descending aorta, which is right there, should be on the left of the spine. And then, of course, the IVC should slightly be on the right and more anterior to the aorta. And did you know that just with this picture alone, if the structures, as I've mentioned them, are normal, I mean in the normal location and the normal position, then with this alone, you're confident to say that this is normal atriositus, or something you call situs solitus. What this simply means is that these vessels will normally go and connect to the right atrium and to the left atrium, and the left atrium and right atrium are actually the left and right. I don't know if that makes sense. Sometimes you can have the left atrium positioned on the right atrium, and you can have the right atrium positioned on the left atrium. Structurally, it is the right, but on the left, and the left on the right. But once you have this normal situs, abdominal situs, it is a confirmation that you have normal atriositus. Not ventricular, just normal situs. And the reason I say not ventricular is because it is normal for you to have, it is possible for you to have a normal atriositus, but then have abnormal cardiac situs. So, for example, you can have normal situs solitus, but with dextrocardia. And this is the case that was published in 2021, I think. And it's a baby born in Uganda. I encourage you to screenshot this and have a detailed read about this. So it is possible to have normal atriositus, but with dextrocardia. So you look at the position of the heart, look where the apex is pointed. Is it the same side as the stomach? Is the stomach on the left side? If your answer is yes to this, then you know this is a normal cardiac situs. And this happens in whatever baby position. You can still look at the baby, look at the heart, ascertain that the apex is pointed the correct way, and then you'll be able to confirm that this is normal cardiac situs. So as you know, the norm with us at Ultrasound Africa, we love interaction. So this is the first quiz for you. And I'm going to launch it right now. So I want you to tell me whether this is I want you to tell me what presentation this baby was in for this to be normal situs. What presentation was this? Was it cephalic or was it breech for this baby to be normal situs. Simple quiz. I'll give you 1 to 2 minutes to log in your responses. Usually the poll shows up as a pop-up on your screen. If you don't see it, please go to the chat and scroll up within the chat. You'll see a section which says poll. It's not so far off when you go to the chat. I don't see any responses yet.
All right, so we have one response now.
We have 2 responses. We'll give it 1 minute and see what people say. Is that baby in cephalic presentation or is the baby in breech presentation? Good. I see the answers coming in. Good, good, good. Gerard Mugumia and whoever else is responding within the chat, don't type the answer in the chat. There is a section for the poll where you can answer by clicking and sending the response. Don't type the answer in the chat. We have 30 seconds. Okay, good. I'm going to close the poll in about 10 seconds. I'll close the poll. Okay, so we have 13 responses. And let me close the poll first so that people do not rig the results. So we have 13 responses and 62% think this baby is breech. 38% think this baby is cephalic. Daniel Kasaija, I've seen your response. It says cephalic, but it is not counted among the poll because you typed it. So imagine yourself as this baby. Turn yourself to your left side and position yourself in breech. Sorry, in yes, in breech. Would that really be the picture you get? I don't think so. This baby was cephalic. The head is down and the legs are up. And it's turned on its left side, which is why we have the apex of the heart pointing down. I was actually positioning myself, I was imagining myself as a fetus. That's why I'm speaking like that. But this is a cephalic presentation and not a breech like 62% think.
Edwin?
Yes, Benjamin.
If you could just expand on that, we think that also it could be transverse with head on the right side.
It could be a transverse with head on the right side. Let me try to imagine that happening. So baby's head on the right. Yes, it can be a transverse with baby's head on the right as well.
Yeah, so I'm just gonna put this across that tomorrow We'll be having this as a practical. So if you can come and join us in the practical session, then that will be very great. The participants who are in today. Today at the Ernest Cook Ultrasound Research and Education Institute, we'll be able to demonstrate these kind of views and images live tomorrow, starting at 9 to 2 p.m. East African time. Thank you.
Thank you, Chugume. So now let's move on from situs. Let's look at the four-chamber view. I love the four-chamber view. To me, it is the most beautiful view of the entire fetus. And surprisingly, it's also the most important view. The reason why it's the most important is because the four-chamber view is abnormal in about 60% of all cardiac abnormalities. It means if you have a normal four-chamber view, then you can roughly say you have excluded about 60% of cardiac abnormalities. That's how important it is. And there are three types of, or three ways of looking at the four-chamber view. So it can be apical, like the image on the extreme left, or it can be basal, like the image on the right. So what basically apical is when the apex is up, basal is when the base of the heart is up. So apical, basal, or it can be transverse, where the septum is more horizontal. People call this the septal view because it's good for examining the septum of the heart. But this is a very important view of the baby's heart. And the good thing is the rules for assessing the four-chamber view are the same, whether it is apical, basal, or lateral. The rules are the same. You still need one rib on each side of the heart, and your heart should fill up 30% of the thorax. I'll go into the details of other things about the four-chamber view, but the rules of examining the four-chamber view are the same whether it's apical, basal, or lateral. So for us to appreciate the heart better, I think it's best to slow it down a bit so that we can see it in real time and slow at the same time. So let's have a look. I slowed this down so that we can appreciate some of the things. And I'm going to be pointing out a few things that you expect to see in the four-chamber view. Let's start with the ventricles. So the ventricles should roughly be the same size. So that should be roughly the same size as this. It is possible to have a slight prominence of the right side, especially in the third trimester, but they should roughly be the same size. The left atrium, this is the most posterior. It's closest to the descending aorta and to the spine. And the right ventricle is the most anterior. So it's in the heart, it's the most anterior section. So anterior is there and posterior is back this way. The apex of the heart, which is this, is formed by the left ventricle. And the right atrium connects with the right ventricle via this valve, which is the tricuspid valve. On the left side, we have the mitral valve, which is a connection between the left atrium and the left ventricle. The ventricular septum, which is this, with atrioseptum, or the primum septum, which is this part here, come and fuse with the tricuspid and mitral valves to form what we call the crux. So the crux is right there in the center, and it's the junction where all these four structures meet: the primum septum, the tricuspid, the mitral, and the interventricular septum. One thing you notice is that the tricuspid valve attaches to the septum slightly lower than where the mitral valve attaches. So I say lower, I mean towards the apex. So the tricuspid valve attaches more apically than the mitral valve, and we call this differential insertion or offsetting. It's very important. It's one of those things you have to look out for, because a loss of that might indicate abnormalities such as atrioventricular septal defect, AVSD. It's very normal to see a tiny bit of fluid around the heart, there and there. It usually measures about 2 and less, so 2 millimeters or less. So it shouldn't be alarming if you see that there. This is how we assess the septum of the heart. It's best to look at the septum of the heart when it's horizontal or in the lateral view, like I explained to you. The reason for this is because it is easy to see if there's a leakage or if there's a communication between the ventricles via a septal defect. It's also important that you use your Doppler properly, so that you don't have too much bleeding or very low PRF where there's a lot of color gain and it bleeds out the entire heart. So optimize your color settings and make sure that you can clearly see the septum. And remember to always examine the septum by sweeping from far down to all the way up towards the arterial or vessel connections. The reason for this is because it is easy to miss a septal defect if you just stand still in one area. Remember, this septum is like a membrane. It's a flat sheet, and the hole can be anywhere in its location. So you sweep through the entire breadth of the septum looking for any leakage or any communication. Okay. I've talked about the PRF. Some authorities do recommend a PRF of less than 3.2 kilohertz as optimal for looking at septum. If it is too low, you get too much color in the heart. If it is too high, you might as well miss some of the small septal defects. And if you thoroughly look at the septum and you don't see any obvious defect, then that is good. But remember, there are usually tiny defects within the septum, but some of those are of no clinical significance because they usually spontaneously close off along the pregnancy or immediately after birth when the pressures normalize postnatally. So I thought it was important to look at a few biometries that we can do with the 4-chamber view. And some of these are things like the axis of the heart. So I found 2 methods of looking at the axis of the heart. The first method is by, I think it's the most popular method. It's by the Fetal Medicine Foundation. I find it in the TISO guidelines and in so many other textbooks by people like Rabi Chawi, who are renowned fetal medicine experts. So this involves a line, an imaginary line from the spine to the anterior part of the chest where the sternum is, and then that is plotted against a line going through the interventricular septum, and that angle there should be about 45 degrees plus or minus 20. So usually 65 to around 25 degrees is normal. I came across a second method of assessing this. So this is by the team at Evalina Children's Hospital. For those who don't know, Evalina is one of the biggest children cardiac centers in the UK, and they have a very research-oriented team there, and they have outed so many publications and they do so many trainings as regards fetal cardiography. And in one of their publications, they talk about this assessment. Rather than going to the front to look for the sternum, they say plot an imaginary line from the spine to the cracks of the heart, and then draw one from the interventricular septum to where the crack basically through the interventricular septum, and that angle should be about 45 to 50 degrees. I find this a bit more practical in some ways because sometimes it's hard to see the sternum, but I also find it a bit hard to do in cases of where, say, for example, the heart is completely displaced on one side, then you find yourself having to chase around the heart to draw your parallel between the spine and your and the baby's cracks, the heart cracks. So I find it a bit challenging, but I also find it quite helpful in some cases. Common axis deviation abnormalities. If the heart is deviated way too much to the left, then you start suspecting things like tetralogy of Fallot, coarctation of the aorta, Ebsen's anomaly. And if the heart is deviated to the right, then think of things like double outlet right ventricle or an AVSD or even a common atrium. So let's look at one other aspect of biometry for the four chamber, and this is looking at the heart size. So you can divide, there are two ways of doing it. You can look at the circumference of the heart, and you can also look at the circumference of the chest. So, and you compare the two. So you get the circumference of the heart divided by the circumference of the chest. And this should give you about 0.3 at 11 weeks, 0.45 at about 20 weeks, but it should always be less than 50 throughout the pregnancy. The same method can be used, but using area. So you can do the same. You can do the area of the thorax and the area of the heart. There are publications about that as well. But I thought I'd look for. I want something in making this presentation. I wanted to make a presentation that is not very complex, so that anyone with a B mode machine able to do a measurement can actually do some biometries of the heart, and these are some of them. If you have an ellipse on your machine, you're able to do these measurements. This is another biometry that I found important. It is called the Global Sphericity Index. So it looks at how spherical the heart is. And this was published by a group of very knowledgeable guys, Devore and his colleagues in 2017. And this looks at the long section of the heart from the epicadium to the base of the heart, and this is the BAL, so it's called basal apical length. And then you also get the transverse section, and the transverse section. So when you divide the basal apical length by the transverse section, you should always get about anything above 1.08 is normal. 1.08 is the fifth centile, and this does not usually change with gestational age. So it's independent of gestational age. So it's a very important measurement. And this has been found abnormal in cases such as cardiac dysfunction due to fetal growth restriction. So as the, say for example, if in a fetal in a growth restricted fetus, there's this burden on the heart, and then there's cardiac remodeling, and then the heart tends to be more round than elliptical, and this index here will give you that objective measurement. So 1.08 is the fifth centile, and any measurement less than the fifth centile is suggestive of an abnormality. I want you to take these measurements in context because I don't want you going measuring this and then baptizing the baby abnormal and confirming it's long gone. But no, these are some of the measurements that might help you to raise your suspicion and look further and deeper. The other thing to do is to look at the heart in end diastolic. So when the ventricles are at their utmost dilatation, ventricular diastole, just before they close, before they start systole, before they pump again. They are at their widest. And here we can do some measurements. And these measurements, some of them include measurements of the valves. And so you can measure the tricuspid valve and the mitral valve during end diastole. And these are measured at the hinges of the valve. So where the valve leaflets attach to the walls is where you take the measurement. Feel free to take a snapshot of this and use it. I've put some of the biometries from 19 weeks to about 23 weeks. The 5th centile, the average, and the 95th centile. So usually the normalcy would be between the 5th and the 95th centile for any of these measurements. And that's mitral valve and tricuspid valve. I'll let you take a screenshot. Okay. The other measurement you can do on the same view is a measurement of the diameter of the ventricles. And this is taken somewhere at the widest area of the ventricle where the leaflets of the open valves reach. So right there is where you take the measurements. And these are also the biometries for the different diameters. So left ventricle, end diastolic diameter, right ventricle, end diastolic diameter. You can take a screenshot as well. And you can use this to guide you. Some of the biometries are very specific. So some of the biometries are very specific. I just saw a message saying empty. I'll get back to that. So some of the biometries are very specific, specific to certain abnormalities. So for example, if one, this is taken during the systole, by the way. So if you took a measurement, if you draw a line from the aorta, which is circled there, to the cracks of the heart, and then divide this into segments. The first segment starting from the cracks of the heart to the posterior wall of the atrium, the left atrium, and then from there to the anterior wall of the aorta, and then to the posterior wall of the aorta. So you divide it into 3 segments, that, and that. And these 3 segments I'll call left atrium diameter. I'll call this left atrium to descending aorta. And I'll call this the descending aorta. So this measurement, the left atrium, so these measurements can be used to diagnose with a very high specificity and a very high sensitivity. You're able to diagnose total anomalous pulmonary venous circulation or connection. So there's something called the left atrial posterior space to diagonal ratio, which is LLD divided by LA. So LLD is that tiny gap between the posterior wall of the left atrium and the anterior wall of the aorta. So that distance there, and divided by the left atrium there, should be about 0.3. And if it is more than 0.35, then it is highly suspicious that that baby has total anomalous pulmonary connection, venous connection. The other thing you can also do is to get the line, the distance between the posterior wall up to anterior wall of the aorta, and then basically the diameter of the descending aorta. That ratio between that gap and the aorta, more than 1 is highly sensitive of total anomalous pulmonary venous connection. And basically, what that abnormality is where these veins, the pulmonary veins, abnormally connect or miss connection to the left atrium. They will bypass, and this left atrium will not be connected to the pulmonary veins, or they'll connect, but via another blood vessel or via another connection, could even be the right atrium. So I would say it's an important biometry to perform as well. So let's have a look at the left outflow tract. And again, I'll show you a small clip of how to So there are basically two ways of doing LVOT. First, you get to the 4-chamber, angle slightly, cardiac, cephalad, and you get the 5-chamber view, like that. Or you can actually completely rotate the probe towards the baby's right shoulder, and you'll get something looking like this. These are the two ways of having, of assessing the left outflow tract. The first one, the 5-chamber view, is called the 5-chamber view because it shows you the right atrium, the right ventricle, left ventricle, and left atrium. And then the 5th chamber is the root of the aorta. So this becomes the 5-chamber view. Whereas this only shows you the right ventricle, left ventricle, left atrium, and the ascending aorta. This 5-chamber view is preferred by fetal cardiologists, well, at least the ones who taught me, preferred the 5-chamber view to the rotation one, where you rotate the probe towards the right shoulder. And the reason for this is because the 5-chamber view gives you a better view of the perimembranous septum. So it is easy for you to miss perimembranous VSDs if you use the rotation method than the 5-chamber view. So in my cardiac training, I was told to always use, were always told to use the 5-chamber view rather than the rotation view. But sometimes it is very difficult and you find yourself having to do the rotation and showing the entire ascending aorta. So again, let's slow this down and have a look at the left outflow tract. And here you get to see some of the structures of the left outflow tract. I'll be taking you through some of them. So the angle between the septum, that septum, and the ascending aorta is always wide. In cases of conotruncal abnormalities, say for example, tetralogy of Fallot, transposition of the great arteries, double outlet right ventricle, this tends to be more straight than angled. So you have the aorta almost going straight, continuous with the interventricular septum. So it's an important sign that you have to look out for. The other thing you have to look out for is continuity. So there's continuity at the posterior wall and continuity at the anterior wall. The posterior wall of the aorta is continuous with the mitral valve, the anterior leaflet of the mitral valve. And then the anterior wall of the aorta, the ascending aorta, is continuous with the interventricular septum. And if there's discontinuity, then we think of things like tetralogy of Fallot or common arterial trunk. The aortic valve leaflets are what you're seeing right there, this white thing that keeps showing and going, showing and going. And it's supposed to show that way. These leaflets are thin. And when the heart contracts, they are flattened out along the walls of the aorta, and that's why they disappear. If during the systole, or if during ventricular contraction, these leaflets are persistently seen, it is most likely because they are dysplastic or they are thickened, and that's why you're able to see them. So it's important that you see them open and close or disappear, and they should be that thin. Some biometries of the left outflow tract. So we measure this in systole, in ventricular systole, at the moment where you can barely see the leaflet. So before they completely disappear is where you take the measurement. And the reason you want the leaflet there is because it's your landmark. It will tell you where the annulus of the valve is. And these are some of the normal dimensions from 19 weeks to 23 weeks. Again, you can take a screenshot if you need. And always remember that the technique has to be perfect for you to get these measurements done so that they are actually usable. Otherwise, if you get differently, then if your views are different from what the parent research that actually produced the nomograms says, then whatever it is you're measuring is wrong, and then you'll be getting you'll be giving a false diagnosis to your patients. So let's have a look at three vessel view. So the three vessel view is basically the pulmonary trunk, which is the longer and wider part. And then you have a transverse view of the aorta, and you have the transverse view of the superior vena cava. Of the three, the pulmonary trunk is the widest, followed by the aorta and then the SVC, in that order. And they also are arranged in the same order from anterior to posterior. So the pulmonary trunk is more anterior compared to the aorta, compared to the superior vena cava. Any change in this orientation or in the size and the calibers of these blood vessels should make you suspicious of heart abnormality, and then you should look more critically and make sure that you are having your sections at the correct horizontal section and not oblique. And that's the same. The three vessel view. Of course, it goes slightly further up to the baby's neck to show the three vessel trachea view, but you can see and appreciate the pulmonary artery right there, the aorta, which is a round ring there, and then the superior vena cava. In this view, we also get to see the thymus. So the thymus is this part here. You see it's different from the lungs on the side here. The lungs are a bit bright here and there, but it's a bit hypoechoic, but it's central, just anterior to the pulmonary trunk right there. It's a good thing to see. It's important to see it because it's usually missing or hypoplastic in certain abnormalities, certain chromosome abnormalities like the George syndrome. So seeing it there is a good thing. Okay. This is a three vessel view in third trimester, and I wanted to show and make note that kinking of the ductus arch, which is completely normal in the third trimester. It's something that happens as the pregnancy progresses. So this is the pulmonary artery, the trunk, and then the narrow part more posterior to the pulmonary artery is the ductus arteriosus. This is the aorta, it's in transverse, and that's the superior vena cava. The pulmonary artery branches into right and left. It's common to see the right branch than the left branch, but usually branches into it does branch into right and left. Just superior to the three vessel view is the three vessel trachea view, which I want to show you again here with the same video. So three vessel trachea view is just basically when you have the pulmonary artery, and then you're also able to see the aortic arch, and these two are coming and joining to form a V, which then goes into the descending aorta. This is more, you find this more superior and with a slight tilt to the left of the 3-vessel view. And when you put color Doppler, the color should be same direction of flow. So from anterior to posterior. I don't know if I'll be able to play this again. Okay, won't let me. Same as here. So the red was because the baby was facing with the spine towards the probe. So the posterior part of the fetus was closer to the probe compared to the anterior part of the fetus. And you can see in this one where the baby is face with the spine towards away from the probe, you have the flow all blue because it is coming from anterior to posterior with the spine at the back. You have it all blue. And this is our second quiz. I'm going to quickly launch this quiz and then I'll play the video for you. So I want to know if you think this color Doppler is normal. I haven't played it yet, but I'm going to play it now. Do you think that Doppler signal is normal? Yes or no? I need to see the polls coming in. I'll give it about 1 or 2 minutes. So the quizzes today are quite simple. And if possible, I would like to pick someone from the respondents, whoever is willing to tell me why they think it is abnormal. So if you want me to pick you, please go into the chat and tell me to pick you. So far, 5 people think this is abnormal. No one thinks it is normal. I think it's very obvious. 5 people think this is an abnormal color Doppler flow. And no one thinks it's actually normal. Does anyone think it's normal? No one. Not even one.
Edwin,
Yes,
do you want me
Benjamin?
to answer as well?
No, you're going to cheat, so I'll not let you answer.
Okay.
Okay. Jacqueline Nabandeke says, I don't know. I like the honesty. So I want... Philmon says his is not flowing. Why is it not flowing, Philmon? So I want to pick someone who thinks it's abnormal and someone who thinks it's normal. And then I will tell you what I think as well. Let me go and see. I'm about to close the poll. I'll close the poll in the next 30 seconds. So far, no one thinks this is normal. Everyone thinks it is abnormal. Marion Choxima thinks it is abnormal. Did you mean abnormal or abdominal, Marion? Abnormal. Good. Are you? Can I unmute you, Marion, and you tell me why you think it's abnormal? Let me unmute you. Let me find you. Marion, where are you? Marion, I have unmuted you. If you can please explain to us why you think this is abnormal. Marion, we're waiting for you. Marion, are you there? Okay, I'm going to unmute. There's Philemon and there is a CY. I'm going to unmute. Let me see. I don't know who CY is. Let me hear from CY. It says CYMOH. I've unmuted you. CY, tell us what you think about the flow. Is it normal or is it abnormal?
Yes, good evening.
Yes, good evening.
I think it is abnormal because it's showing different colors, and these are the same vessels and they are flowing in the same direction. These are different vessels, yes, but it's the pulmonary artery and the aorta, and they flow to the same direction, so they should have same color flow. But in this case, one is flowing. Let me see the video. One is flowing towards, so kind of abnormal. So there is retrograde flow in one of them. So that is my take on it. Thank you.
Thank you. Thank you. Thank you so much. That was a very clear reasoning. Now, I saw someone here. Let me see. Philmon. Let's see. Philmon, I have unmuted you. I'm not sure if you had a different view or the same view. Philmon?
Can you hear me?
I can hear you.
Yeah, now I have not seen the video move. That's why I was raising my up my hand. I don't know if I'm the only person or even others.
Oh dear, sorry about that. On my side, it is moving. I can tell you what it is saying. Maybe you can tell me the answer. But not to worry, all this will be on our YouTube channel, and then you can go through it and have a look as well. Yeah?
Okay, no problem.
Sorry about that, Philwood. Okay, I'm going to find, I saw someone, what is Vitus? Vitus? Vitus. Vitus will be the last, and then I can close this poll. So Vitus, I have allowed you, Mike. Vitus, I have allowed you, Mike. Yeah, I've seen your message, Marion. You're in a noisy place, so you couldn't answer that. That's understandable. Thank you, though. And I've seen your reasoning that the three chamber on the three chamber, the flow should be the same direction. Okay, I don't see Vitas coming in, so I'm going to close the poll and then tell you what I think. Okay, so it is normal. This is normal flow. I know the colors are a bit confusing because you're seeing red and blue, and yet we're supposed to have the same color flow. So it's supposed to be either red or blue. But look at these blood vessels critically. If the probe is our center of reference, is the aorta flowing towards the probe? Yes. And is the pulmonary artery flowing away from the probe? Yes. And for that reason, that's why the pulmonary is blue and the aorta is red. So it is true that they're all flowing to the back or towards the posterior aspect of the baby, but in reference to the probe, they are flowing in opposite directions. This is I call it an artifact, but this is something that can easily confuse a sonographer to think there is abnormal or retrograde flow in one of the vessels just because they've alternating colors. But this same baby, if the probe is oriented properly, you easily get an appearance similar to what I showed you before, similar to this. So in this case, they're all blue because in the aorta, if the probe is up there, the aorta is flowing away from the probe. Remember, our reference for color Doppler is probe. So the aorta, the flow in the aorta is away from the probe, so it is blue. Same as the flow in the pulmonary artery. That's why it's also blue. And in the section before, where we had red, it's because the baby is oriented in such a way that the flow is moving towards the probe in both the aorta and the pulmonary artery. So it creates that red V shape or red V sign, which is almost the opposite of the blue one, which is away. But in this case, this is normal flow because they're all going to the posterior aspect of the baby, which is where they're supposed to flow. It would be retrograde if within the aorta, the flow was from posterior to anterior. Then there I would say there's retrograde flow, but this is absolutely normal with the baby. It's just a question of position. And I think Vitas hinted on it in the chat. I saw him say it could be to do with the orientation. And yes, you are correct about that. So with these views of the situs, 4-chamber view, LVOT, 3-vessel view, and the 3-vessel trachea view, with that, you have completed cardiac screening. And with this, you're able to pick up the vast majority of heart abnormalities. If you follow the guidelines like I told you, and if you follow the same sequence of scanning, a transverse section from abdomen all the way up towards the baby's neck, and you critically study the 4 chambers, the outflow tracts, and the valves in that much detail, you'll be able to achieve comprehensive cardiac screening. These are some of the references I used for this presentation. I have, like I told you, I've compiled another presentation, which I could not put in this because then we'd spend the whole night here. This will be looking at abnormalities of all these views that we've looked at. So I've looked at abnormalities of this 4-chamber view, abnormalities of the left outflow tract, abnormalities of the 3-vessel view, abnormalities of the 3-vessel trachea view, in all the different aspects in terms of B mode, color mode, and this will help us to understand and to put into context what we have learned today in the presentation of cardiac screening. I thank you all for attending. And now I'll take some questions, please.
All right, so we thank you, Edwin, for this wonderful presentation. It was a really big insight into the fetal cardiac ultrasound. Thank you very much. So we will entertain questions now. And as we wait for questions, we will ask you to go into the chat. There's information in there. And there's a link to our YouTube channel. There's also a link to our LinkedIn platform. There is also a link to our website. So our website is www.ultrasoundafrica.org. Go visit there for great resources about ultrasound. And also we have a quiz right there on the website and a case of the week. So you can go on there for quite a few resources for your own good. So let's take questions. If you have a question, please raise your digital hand or put it in the chat. We'll be able to pick you up. So there is CY. Yes, we will unmute you and then you can ask your question. Yes, Edwin, if you can unmute CY.
Okay. Okay. See why you unmuted?
CY, if you can unmute yourself on your side, please.
Yes, I wasn't ready for a question, but something just came into my mind. Is this what would be the criteria for this fetal cardiac screening in multiple pregnancies, where we have the babies in different presentations or more than two babies? That is my question.
Thank you.
If it is the same kind of criteria to be followed for each baby, or if there is another formulated criteria for multiple pregnancies.
Thank you. That's a good question. Thank you. So cardiac screening for a singleton baby is the same as for a twin pregnancy. It is the same for triplet pregnancy. And in fact, for twins, it is much more intense and in detail because remember, certain risks are increased by the fact that it is a multiple pregnancy. So, for example, in twin-twin transfusion, in twin-to-twin transfusion syndrome, you have a likelihood of cardiac abnormalities. So that means monochorionic twins will definitely need a much more detailed cardiac scan than a singleton pregnancy. But in as far as screening, every pregnancy, whether it is multiple or whether it is single or multiple, gets the same. It's the same protocol.
All right, then. Thank you.
You're welcome.
All right, so someone is asking about share. We can share the link to the YouTube channel. So the link is right in the chat. If you can just go into the chat, there are several links that we have sent in there. Please go and check it out. And also the YouTube channel is actually seated on our website. The website has lots of links that you can go on to. So the website is www.ultrasoundafrica.org. We will also be sharing information just before we close this presentation. There's a few slides that you can get information from that we'll be sharing right after Edwin.
I've unmuted Ronnie Muhenda. I noticed his hand was up.
Thank you, gentlemen, for the presentation. I would like to Mr. Hinda to tell me if there's any recognized protocol for doing this cardiac screening. Because you are going from here and there, is there a known protocol for doing cardiac screening, which we can generally follow? Thanks.
Thank you, Ronnie. Yes, there is a protocol, and this is the protocol I was explaining to you. The cardiac screening in the US, cardiac screening in the UK, cardiac screening in France, or wherever it is, follows the same exact format. Transverse views starting from the situs, sweeping cephalad into 4-chamber view, cephalad into left outflow tract, 3-vessel view, and 3-vessel trachea view. There might be a slight variation depending on the different countries, but that is basically the gist of cardiac screening. And there are publications about this screening. If you visit ISWOG website, you will find some publications there. There are ISWOG guidelines on fetal cardiac screening, which we'll also be sharing on our WhatsApp groups after this. The other place I can see that is resourceful in this regard is the Fetal Medicine Foundation website. They have cardiac training as well there, where you can visit and get some rich resources about this.
Okay, sorry to interrupt. Can I ask again? Especially, yes, when you talked about equipment and how to adjust our equipment for optimize them for the cardiac screening. You didn't talk about the exact grade of equipment we can use. I don't think this can be done on average equipment. It should be equipment, I think, that can give you very good sharp images. Otherwise, there's risk of missing out on pathology. So according to your experience, what kind of ultrasound equipment can we use to get good results? We may not get super results, but basic good results in this cardiac screening.
Thank you. So there's I'll go back to this table. When I started scanning, the machines we used could only allow you to switch on and switch off and maybe enter the patient's name. But things have completely changed. Things have now moved on. There are wonderful machines on the African market even as we speak right now. I've seen some amazing images coming from Africa, from Uganda specifically. So I'm not very concerned about the equipment. But what you're saying is very pertinent because there are also many low-grade machines which will compromise the quality of the image that you get. You're supposed to have a significantly high frequency. The higher the frequency, the better it is for you. But of course, you cannot go indefinitely high in frequency because it also affects the penetration. But for you to see the fetal heart in this much detail, you need high frequency. I talked about frame rate. I can't remember if I was able to manipulate frame rate on the machine I used for training when I was doing my ultrasound trainings way back many decades ago. But machines currently allow you to change a lot. The power is with you to change lots of things on a machine. You can manipulate things like frame rate. You can manipulate things like sector width. You can change things like dynamic range. All these things are able to be done on current machines. If you're able to do this and achieve a frame rate of 40 and above, you're good to go with a cardiac scan. Look at your scan machines. They usually figures up there in the corner, up in the corner. It will show you a figure. Either it will say frame rate, a number, or it will put the number without necessarily telling you that it is frame rate. So, and cardiac scanning is good if you have a frame rate of above 40. Well, they say 35 to 40 and above is good frame rate to look at the fetal heart. The reason for that is because this heart is beating too fast. If you have a high frame rate, then your your temporal resolution is higher. Temporal resolution simply means the machine's ability to tell the difference between what happened 1 second to the next second. If your temporal resolution is low, the machine is not able to. And if it's not able to, it means that the valves will beat and the machine will not even know that the valves beat twice before it created an image. So you have a blurry image of the valves because the valves were beating faster than the machine could create an image. When you go into the finer details of echocardiography or the more complex studies, you don't even you can't perform it with frame rates as low as 40. You need to go all the way to hundreds. That means you need to be able to create, the machine needs to be able to create scan pictures at a rate of 100 every second, which is quite high. So it's kind of a give and take. Can you do fetal cardiac screening with a basic machine? In a trained hand, yes. If you did lots of these, you can somehow do a basic cardiac screening, even with the most basic of ultrasound machines. I believe so.
Okay, so Edwin, there is a research going on, and Ultrasound Africa is part of it. So we will be able to find out whether the basic ultrasound machines that are available in the limited resource setting will be able to help do this cardiac screening. So soon the results will be coming out.
Good. I have opened the mic for Isahaku. Isahaku?
Yeah. Good evening, boss.
Yes, good evening.
Thank you very much. I think I have network issues here, so I've not been able to follow the through of the presentation. But I think I've had, in all I may say, is beneficial. I have two questions, and one of them has to be with like I would like you to go over the technique to acquire the 3-vessel view. Yes, and then the other thing is which cardiac biometry do you have to? Which cardiac biometry are important to take vis-a-vis the higher population in the low resource ultrasound unit like our setting here? Will you be able to do, because in your presentation you've given a number of biometry that you can take. So like I want to know which ones are important for one to take considering the population that you may have at your exposure, and then what are the relevant things to look out for during your measurements. Right, thank you.
Thank you, Saku. Thank you. So your first question was about the technique for 3-vessel view. So I'll quickly play this for us again so that it will remind us. So from the abdominal situs, where the probe is right now, that's where you get your abdominal situs. If you slide your probe towards the baby's head, maintaining a transverse section, you get to the 4-chamber view. 4-chamber view is about the level of the fourth rib. You do not rotate the probe. Simply angling the probe will give you an LVOT, angling the probe towards the baby's head. And the further angulation will give you the 3-vessel view. Further angulation with slight movement of about 4 millimeters will give you 3-vessel view, and then a further angulation towards the baby's head should give you the 3-vessel trachea view. These structures are within 4 millimeters of each other. They are so close to each other, you do not move a lot from one structure to the next. And the baby is small. So most people assume that you have to move a lot from the 4-chamber view to the 3. It is a very slight movement and a very slight angulation for you to be able to move from the 4-chamber view to the LVOT, from the LVOT to the 3-vessel view. But to answer your question, once you've completed the 4-chamber view and you angle slightly, like you're seeing now, you should be able to get the 3-vessel view. You asked about the biometries. So the biometries I showed you, we don't do routinely, not even in the UK. Cardiac screening does not involve us taking any measurements. It is just simple assessment of the baby's heart, of what you're seeing on the screen right now. Look at the position of the stomach. Is it left or right? Start with that. Look at the position of the aorta. Is it normal? Is it slightly to the left? Look at the IVC. Is it slightly to the right and more anterior to the aorta? If that is normal, you have normal situs solatus. Slide to the 4-chamber view. Is the apex pointing the same side as the stomach? If it is, that means you have a normal cardiac situs. Now, for situs, you're covered. Look at the structure of the 4-chamber. Are the ventricles proportional? Are the chambers, is the axis normal? Is it about 45 or between 65 and 25 degrees? If you don't feel confident in doing a subjective assessment of this, then that is when you can take a measurement. If your machine allows you to do an angle measurement, that's when you can do a measurement and try to measure the angle to see if it is. Or if you suspect it is abnormal, then you can go ahead and do this measurement. But these are assessments that you can do subjectively with just assessment looking at them. You do not have to do measurements all this on every scan. The biometries I showed you, I only showed you as things that are possible to do and things that might be helpful if you find yourself stuck and you need to make a decision on whether you think it is abnormal or not. These biometries might help you to confirm your suspicion or raise your suspicion, but you do not have to do these biometries every day. Yeah. And about the more important biometries to do, like I said, every woman should get cardiac screening. Every woman should get the 5 views that you're seeing on the screen right now. Whether it is a low-risk pregnancy, high-risk pregnancy, every woman who is pregnant should get this. And it is usually done between 18 weeks and 23 weeks. But of course, you can also do it much later, depending on when the woman presents, because I understand the challenges of women presenting late for scans. I've worked in settings where women don't present for scans in the correct timing and they just show up late. And you're forced to have a look at the baby's heart even in the 3rd trimester. So it is something you can do wherever the woman shows up. But please make sure that you do all the 5 views: situs view, 4-chamber view, 3-vessel LVOT view, 3-vessel view, and the 3-vessel trachea view.
All right. So Edwin, there's a question. Someone has just sent a question and said the pericardial fluid that you talked about, which is about 2 millimeters. Do you measure this in diastole or systole?
You measure it at its widest, and it's usually at its widest when the ventricle is contracting. So in ventricular systole, when the heart is pumping, is when it is more wide. When the heart is relaxing, then it is filling up the space, and you will not be able to see it.